morning. My name is Yani Camps. I'm one of the training captains here at Collier County EMS. And today we're going to review management of the difficult airway. Okay, a difficult airway can be an airway that has blood in it, has vomit in it, is swollen because of burn injuries or caustic, inhalation, or someone drank bleach, for example. It could also be someone who has had trauma and has either facial trauma or neck trauma, and it's difficult to distinguish, what's the nose and what's the mouth, and they're unconscious and they're not breathing. So today we're going to practice managing those types of airways. Typically, and I'll bring your attention to a model of an airway. Typically what we do on a person, a general, unconscious, unresponsive person who can't, is not breathing on their own or cannot manage their airway. Here we have a model. This is where you breathe from. That's your trachea. And then right below it you have your esophagus. Okay, so typically what we do is we insert a tube, it's called an endotracheal tube, in through your trachea, okay, through your mouth and in through your trachea. We inflate the bulb, and then we use a BVM, okay, and we bag oxygen into your lungs, and we breathe for you, okay. In this scenario, you're going to have the same anatomical activities. You still need to provide that tube to provide oxygen into the lungs, but the airway is going to be either full of blood or full of vomit. If someone was, had just finished having dinner and had a cardiac arrest and went down, they could very easily vomit. If you have someone who had trauma, they can have blood in their airway from coming either from the lungs or from their mouth, for many different areas. So that would make the landmarks difficult to identify. You would have to suction the airway, try to take out any vomit or blood or whatever is present, and then attempt to find the landmarks and insert the tube. So that's basically what we're practicing today. Also, that is an advanced skill that's done by paramedics. However, EMTs can do the basic life support skills, which is with a king tube, which is this piece of equipment right here. And that is a blind insertion, meaning they're not going to look and try to identify any landmarks. They're just going to suction out whatever is in the airway, be it blood, vomit, whatever the case might be, and then they're just going to insert that straight down. And this tube is meant to land in the esophagus, not in the airway. So it's going to fall right underneath it, and when you inflate the bulb, this is going to inflate and it's going to push up on the tongue and kind of clear that area where the airway is, where your trachea is. And then it's also going to plug up your esophagus so the food or vomit does not come out. And then just by bagging the tube, you're going to have airway coming out of this section right here, or air coming out of that section right here and into the trachea in a passive manner. And now this is for a basic level. They don't have to be able to identify any landmarks. All they have to do is clear the airway with the suction and then just insert the tube. So in this station, you're going to see both types being inserted to secure an airway.
Hello, I'm Sheri Rapisarda. I'm an EMT with Collier County EMS. And what I'm demonstrating today is obstructed airway with king tube insertion. To abstract the food or any obstruction from the patient's airway. What I'm doing now is I am bagging the patient with oxygen, pre-oxygenating the patient before I insert my king tube. The king tube is for the purpose of opening the airway with, in place of using an ET tube. ET tube is an endotracheal tube, just a tube that is inserted that a paramedic will use. It's an advanced airway placement. This is a basic airway placement. Here, and I'm just going to push this down into the airway, and this goes into the esophagus. Push that in, and what this does, and I inflate my tube, And what this does is this blocks off the esophagus and opens up the tracheal where I can bag the patient and have an airway. And I pull out on the tube slightly, and after I'm bagging the patient, I will check for lung sounds to make sure that the patient's lung sounds are equal and bilateral, and then I will continue to bag the patient and stabilize his airway.